डॉक्टर वेदांत ने कर लिया क्या चेक, स्क्रीन चेक? म्यूटेड है शामिक जी आप.
Both of them I've already checked.
Okay, great. I had a talk with both Dr. N.C. Prajapati sir and Bal sir, and I have also informed Dr. Piali madam also. So I think we have today 3 of them with us.
I'm there, Sushma.
Oh yeah, great. Ma'am, welcome.
Welcome, Didi. Welcome, Dr. Manmeet. Sorry, I was just calling
welcome,
you.
Manmeet ji.
Yeah, actually, I was clicking on the last month's link and I was thinking why it is coming invalid.
Detox की कितनी जरूरत है?
Good afternoon, everyone.
Good afternoon, ji.
Good afternoon, ji.
Good afternoon, everybody.
Very good afternoon, Dr. Prajapati.
Very good afternoon, sir, and welcome.
It's always a pleasure to be there in these academic meets.
The pleasure is here as well, by letter. Welcome, Dr. Harmesh Mai, sir.
Good afternoon, and
Very good afternoon,
good
sir.
afternoon, everyone. I have just arrived. मैं पानी पी के आ रहा हूँ बस.
कोई बात नहीं सर, आराम से.
Welcome, Dr. Harmesh Fancy.
He's gone to have some water.
Right.
Good afternoon, madam.
Very good afternoon and welcome.
Yeah, madam. Our department is presenting today.
Yeah, I know
Most
that.
welcome, ma'am.
I'm
Yeah.
so very
welcome.
thrilled to have you here.
Yeah, ma'am. Yeah. How are you, madam? Oh.
Ma'am, it's 3 o'clock. Shall I start?
Yes, Dr. Shamik, we can start.
Yeah.
Absolutely.
Yeah,
I was just
yeah.
going to tell you the same.
Yeah.
Okay.
Very, very warm welcome and a good afternoon to all the participants for today's edition of the PG Pearls. We've been having quite a few series and it's been a very encouraging response. We have had some eye-opening insights by our youngsters. The entire purpose is to initiate during the postgraduate training some acclimatization with adolescent health. And what started off as an acclimatization has turned out into some real eye-opening and expert case discussions, journal presentations. So continuing this journey, today we have two very, very bright young minds who will be presenting to us. There will be a case discussion by the Department of Pediatrics, D.Y. Patil Medical College Hospital and Research Center from Pimpri Chinchwad, Pune. The presenter will be Dr. Vedant Tandon, and he's being mentored by Dr. Shraddha Salunke, professor in pediatrics. And we are also blessed to have the professor and head of department of the same department, Dr. Shailija Mani. The presenter will be Dr. Vedant Tandon, who is a junior resident. We are also very, very fortunate, lucky, and privileged to have with us Dr. Chavi Singh, the junior resident of the Government Medical College and Hospital of Chhatrapati Sambhaji Nagar. And she will be talking about the PMOS, a mystery to be solved, and will be mentored by Dr. Shilpa Pawar Shagar, an associate professor in the same department. I hand you over now to Dr. Shushma Desai, our chairperson, for her opening remarks before we start with the proceedings.
Yeah, so very good afternoon. It's a sheer pleasure and honor on us. I welcome you all to the PG Pearls, a very, very kind of we would like to say is our brainchild, the AHS brainchild, and we are having a really good response from all the medical colleges and the PG students, and we are thrilled to have the very vibrant PG students with their very, very knowledgeable and I would say esteemed mentors over here. I heartily welcome the experts of today's webinar, Dr. Piali Bhattacharya, who is the chairperson-elect of AHA, and she belongs to Lucknow Medical College. I welcome Dr. Harmesh Bain sir from Ludhiana. He's our senior AHN, and we look forward to have a lot of inputs and guidance from him. And a very, very dear friend and respected AHN, Dr. N.C. Prajapati sir. It's very, whatever I say is less for him. Sir is very humble. He is from Agra, and we welcome all the three experts. We would love to have, before that, I would like to introduce our the PG Pulse coordinator and a very, very enthusiastic, dynamic person, Dr. Manmit Sodi, who belongs to Ludhiana. Apart from all these experts, we have Dr. Shailaja Mane, eminent AHN and the head of the department, D.Y. Patil Medical College, as well as Dr. Shilpa from Chhatrapati Sambhaji Nagar Medical College. So with all this, I wish the best to the presenters, Dr. Vedant and Dr. Chavi, and let us start today's webinar.
Thank you, Shushma ji. And our respectful regards to our national coordinator, Dr. Sameer Shah, and also to all the eminent personalities and who will be guiding us during today's presentation. The first presentation, let me call upon Dr. Vedant Tandon from the D.Y. Patil Medical College to start his screen sharing, and all the very best for your presentation.
Thank you, sir. Good afternoon, everyone. My name is Dr. Vedant Tandon. I'm third-year resident from Dr. D.Y. Patil Medical College. Today, I'll be presenting a case discussion from Crushes to Crisis, a girl between love, school, and the mind. First of all, I would like to thank Adolescent Health Academy and IAP for giving me this opportunity. And my mentors are Dr. Shailja Mane, professor and head of the department, and Dr. Shraddha Salunke, who is professor in the Department of Pediatrics. So a 12-year-old girl, second-born child to parents with non-consanguineous marriage, came to pediatrics OPD with her parents complaining of sleep disturbances 1.5 months, with difficulty in initiating and maintaining sleep, and she remained active throughout the day despite decreased sleep. There was irrelevant, excessive talking, which was reported by the parents, which was difficult to interrupt. There were frequent topic shifts, and the parents found very difficult to follow her train of thought during conversations. There were anger outbursts since 1 month. There were frequent irritability. She was shouting. There was verbal aggression, occasional throwing of objects, which was very disproportionate to the triggers. And subsequently, there was decline in scholastic performance since 1 month. On further inquiry, the parents reported that since 1 month, the girl believes that she was in a romantic relationship with an 11-year-old boy who is deaf and mute. She frequently spoke about him, expressed a strong emotional attachment, and insisted on maintaining contact with him despite parental objections. The parents consulted an outside psychiatrist 1 month ago, after which she was started on medications, olanzapine, etiozolam, valproate, trifluperazine. And after this treatment, her irritability reduced, sleep also improved, but she persistently talked about this boy. And after her exam results, prior to us presenting, she became emotionally distressed, and there were continuous episodes of crying, repeatedly poured water over herself, and persistently demanded to visit the boy's house. She started throwing utensils when she was restrained by the family members. And owing to these worsening symptoms, she was brought to the pediatric OPD for further evaluation. There was no history of fever, headache, recent infection, head injury, seizures, loss of consciousness, vocal neurological deficit, substance use, or intake of any medication elevating her mood. There was no history suggestive of obsessive compulsive symptoms, self harm, or suicidal tendency. There was no significant psychosocial stressor reported from the family members. There was no history of previous hospitalizations in the past, no history of any surgery, and no history of any similar illness in the past also. No history of any thyroid disorder. Personal history, she was sleeping inadequately, only 2 to 3 hours a day, and she remained active throughout the day without adequate sleep. Screen time was also 4 to 5 hours a day, mostly on the internet watching romantic serials. Menstrual history, she attained menarche at the age of 11 years. The periods were regular and duration was 4 to 5 days. Cycle length was 28 and requiring 4 pads per day. No history of dysmenorrhea or passage of clots. Family history was also normal. She was the second born child out of non-consanguineous marriage, and there were no history of any psychiatric illness in the family. There was no history of thyroid, autoimmune, metabolic disorder in the family also. And there was no history of death in the family by suicide or absconding behavior noted. She belonged to a lower middle socioeconomic class. Father was a farmer, and he also worked in an unskilled automobile workshop. He was educated till 12th standard, and there were 5 total family members in the family with monthly income of 18,000 rupees. Birth history was normal. There was no history of birth asphyxia. Developmentally, she was normal. No history of any developmental delay or regression. She was previously good in scholastic performance. Uh, Actually, she used to come first or second in the class, but there was decline in the scholastic performance since 1 month. Immunization history was also she was immunized till 10 years of age. Last vaccine taken Tdap in March 2024. Uh, she used to have mixed diet, veg and non-veg, and 2 major meals with frequent snacking 2 to 3 times a day, like chips, sweetened beverages, and total calorie deficit of 200 kilocalories per day with protein deficit of 6 grams per day. So her strengths were she was a bright student, good pre-morbid functioning. Thus, parents were very supportive, and there was no history of any substance abuse. She lived with her parents and 2 siblings. Father was farmer, automobile worker, and mother was a homemaker. She was previously active at school, she used to spend 4 to 5 hours on internet while watching romantic serials. There was no history of any tobacco, alcohol, or vaping substance drug abuse. She was crying, irritable, anger outbursts was present, excessive talking, decreased sleep, appetite was also decreased. She attained menarche at 12 years, but there was no history of any sexual activity or abuse, and she was in a delusional romantic belief with the 11-year-old schoolboy. There was no history of any abuse in the family, but there was aggression in the during these 1 month. She was throwing utensils, but parents were supervising her closely, and there was no idea of any suicide intention, attempts, or self-harm. Her weight was 46 kg, height 155 centimeter, and BMI was in the normal limit 19.1. Waist circumference was also 66 centimeter with waist to hip ratio 0.83. Okay. SMR, according to SMR, she breasts were elevated B3 and pre-sexual hair were present. So examination was done in the adequate daylight with verbal informed assent and proper informed consent from the parents were taken. She was irritable, but was maintaining eye-to-eye contact. The attitude towards us was very authoritative. She was moderately built, well-nourished with normal hydration. Vitally, she was stable. There was no pallor, icterus, lymphadenopathy, clubbing, cyanosis, edema present. Head-to-toe examination was normal, except there were firm acne present on the face. So mental state examination was done. She was not conveying the mood, and the affect was irritable. However, the cognition was appropriate. There were ideas of love with variable stream, but there was no idea of any suicide. She was denying auditory hallucinations, and even during examination, no hallucinating behavior was noticed. There was insight of 1 by 5. She was denying the illness, and judgment was impaired. CNS examination was done. She was normal, except the speech was very incoherent with variable rate and tone, increased volume, irrelevant sometimes. Rest all systemic examination was normal. Genital incident, there was no evidence of any sexual abuse or any vaginal discharge. So on the basis of history and examination, the differentials considered were conversion disorder, acute transient psychotic disorder, hypomanic episode, adolescent crisis, autoimmune encephalitis. So investigations were sent, which revealed the HB was 12.4 in the mild anemia. HbA1c was in pre-diabetic, she was 5.8, and she was deficient in vitamin D and vitamin B12, which came 9.4 vitamin D and 101 vitamin B12 levels, which were corrected later on. MRI was done normal, EEG was normal, and ANA blot was also negative. So child psychologist assessment was done, and she stated that she was preoccupied with a deaf and mute boy and expressed a desire to live a similar mute life and repeatedly stated her intention to marry him. This was persistent in her thoughts for approximately 1 month, and she also spoke about romantic and physical themes in an immature and socially inappropriate manner. So the final diagnosis after admission, according to DSM-5, was bipolar type 1 disorder with mania with vitamin D and vitamin B12 deficiency. So she was admitted under joint care of the adolescent health physician, pediatrician, and a team of psychiatrists who are trained to manage child and adolescent psychiatric cases. A multidisciplinary team approach included a psychiatrist, where she was started on pharmacological tablet olanzapine 2.5 mg twice daily. Pediatrics and adolescent medicine started on vitamin D supplementation, vitamin B12 supplementation. Psychological intervention was done. Cognitive behavioral therapy was given every alternate day. Interpersonal and social rhythm therapy was also, which helped her to improve the social outcomes and the relationship status with the parents, and also improved her sleeping style. Lifestyle modification and stress management was done. Encouraged healthy micronutrient-rich food. Yoga was taught, and we also restricted the use of internet. Also, the nursing care was very important, who monitored sleep, food and water intake, encouraged medicine adherence, and also recorded the mood, behavior, and sleep pattern. Family was also involved. They were taught to promote calm and supportive and non-judgmental communication, educated regarding the early warning signs like suicide, and also minimize stress, conflict, and overstimulation of the symptoms. Now on follow-up, she's on regular follow-up with pediatrics, adolescent medicine, psychiatry, and child psychologist. Last follow-up was done on this month only, 1st July. And she's currently on tablet olanzapine, and she's compliant with her medications. The episodes of anger have reduced. She takes care of herself. Biofunctions are normal. Her scholastic performance has also improved. Appetite and sleep improved. So she was diagnosed with bipolar disorder. It is a chronic mood disorder, and it is very different from the adult bipolar disorder. In adolescents and in children, the pediatric disorder is associated with marked functional impairment, and there is decreased sleep. The academic performance decreases, interpersonal difficulties, maintaining family relationships, and there is increased risk of self-harm also. Irritability is the symptom which is very much reported by the parents in the initial stages. Risk factors include any history of bipolar disorder in the family, child abuse, any trigger, any history of bullying in the schools, excessive internet use, excessive gaming platforms, stressful events, and substance abuse like cocaine or any drugs. Vitamin B12 deficiency can also precipitate this bipolar disorder, even thyroid also. Diagnosis based on DSM-5 manual and ICD-11 criteria. Mania requires a distinct period of elevated mood, expansive and irritable, with increased energy lasting for at least 1 week, where accompanied by at least 3 or 4 manic symptoms, causing marked impairment in the functions. Management, it requires a multidisciplinary approach, like we did this in this child. Pharmacological management, lithium, second generation antipsychotics, valproate, but valproate shouldn't be used in girls. It can, if used, should be used cautiously because it causes teratogenicity and also polymetabolic ovarian syndrome, hirsutism also. Psychological interventions are very important, like psychoeducation for the patient, caregivers, cognitive behavioral therapy. Family should be trained, interpersonal and social rhythm therapy, school counseling, and academic support also. Family should be educated regarding the early warning signs of the relapse and also the ideas of suicide, self-harm, or homicide also. Importance of medication, maintaining regular sleep patterns, stress management, and avoiding extra family conflicts. With sustained pharmacotherapy, psychological interventions, and regular follow-up, these symptoms decreases and also improve psychosocial functioning. So prognosis can be better if we manage all these things. Early diagnosis and appropriate treatment is very important for the prognosis. And the poor prognosis, the factors which include are the early age of onset, delayed diagnosis, poor treatment, family conflict, presence of psychotic symptoms, or any comorbid psychiatric disorders also. So the take-home message, so mood disorders, they present differently in adolescents. Like you told, with irritability, aggression, academic decline, and a good psychosocial assessment for heads or shades is very essential to identify precipitating factors, family dynamics, peer relationships, school issues, and risk-taking behaviors. Early recognition and accurate diagnosis is important, and a comprehensive evaluation should be done to rule out any substance abuse, autoimmune encephalitis, thyroid disorders, or any other organic conditions. And management requires a multidisciplinary approach: pharmacotherapy, psychosocial education, family education, psychological intervention, school-based support. Everything is important. Family psychoeducation and adherence to the treatment improve the long-term outcomes. Regular follow-up is essential to monitor the symptom control, medication adverse effects, growth, development, academic functioning, and psychosocial adjustment. Early intervention improves prognosis, and this helps adolescents achieve better emotional regulation, social functioning, and quality of life. Thank you.
So thank you, Dr. Vedant, for that excellent presentation. And first of all, let us have comments from the experts. I would like to invite Dr. Harmish Bain sir for his comments.
Good afternoon.
Good afternoon.
Good, Vedant. You have done a wonderful job. Quite exhaustive presentation. I would suggest your third year PG and in the exams, speed
Yes, sir.
little slow so that examiner gets the uh, good idea about the case. Otherwise, it's good. And at one place, you have mentioned initiation of sleep was delayed. Means you mentioned 2 to 3 hours sleep only.
Yes, sir.
So per day means this is in 24 hours.
In 24 hours, sir. In 24 hours, she was taking only 2 to 3 hours a day, and there was difficulty in initiating sleep and then maintaining also. And even on the decreased sleep, she was very irritable. She was not feeling drowsy.
So we need a little more insight into the settings of the sleeping area, or means what is there, what is the equipment present, and what does she do before going to sleep? Because if light is there, then melatonin is affected and there is delay in the sleep. So was she used to seeing these emotional movies before sleep? Then is another factor. So little more detail, I think, will be better. And yeah, minor things. Minarchy at one place you have mentioned 11 years, and in the other place it's 12 years.
So the girl was 12 years old, and she was in a delusional love with a 11-year-old schoolmate, sir.
So I think we have to recheck before presenting. And another thing, this is a universal sort of finding among PG students when we do go for exams. You mentioned moderately built. What do you sense from this? What is moderately built? How did
So,
you say or decide she was moderately built?
yes. Sir, on the basis of BMI, the muscle bulk, and she was appropriate for the age. There was adequate muscle mass, sir, and subcutaneous weight.
What
She
will
was
be
not thin.
other categories? Then other should be mild and severe. So do we ever use these terms? So built is a stature. It's a stature. We have a look on the patient and we decide the stature. And stature is divided as ectomorphic, mesomorphic, and endomorphic. So it's built is stature. So we have to mention accordingly. Means ectomorphic is lean and thin and height is good. And endo is short stature and chubby and thick. And meso means in between. So this should be the standard term. And otherwise, this is a trend. Means we mention this type of build. Then you also mentioned her attitude was authoritative. Means you should explain little more while presentation. So what is authoritative attitude by the patient?
So she she was, when we were questioning her anything about the history of when we were asking her, she was also asking the similar questions to us, and first she was denying everything. So uh, so this attitude was very, she was very dominant, commanding, sir, and in a very overconfident manner to control the questions, sir.
So little more details may be mentioned. Another thing mentioned is her judgment was impaired. So what were the parameters indicating impaired judgment?
Sir, judgment, she whenever we used to ask uh, in the situation when where are you currently, or uh,
That is orientation.
yes, and if we were trying to give any situation like what um, uh, what will you do if the car hits you, or then she was giving, if the car comes suddenly in front of you, then she was throwing some uh, she was not telling us correctly.
So we need to be clear on this issue, and
She was
better
aggressive.
to mention a few explanatory notes along with this type of finding when we write. That will give you credit, more credit. Another thing is you mentioned in one slide differentials for this condition like convergent disorder, and there are few more conditions. So ideally, once we take history, we do examination, and then we think of differentials. And here it's important to mention different positive and negative or supportive or features of each of these conditions. So that gives a better idea that what you have, and then we decide in about which of these conditions there are more number of factors or findings. So then we sequence it accordingly. Number one is this diagnosis, number two like this. So that again improves your scoring. Then some spelling mistake like plantar reflex you have mentioned, palmar reflex, so maybe just autocorrection or something. And finally, in this patient, what do you think? What is the risk factors for this problem?
So first thing, the use of excessive mobile phones, sir, and watching these kind of content on the phone. Secondly, the precipitated by vitamin B12 deficiency also. Some form of anemia was also there. And in school, she was a topper initially, and I think the peer pressure led to all these things. Emotional stress.
Again, important to mention features of B12 deficiency causing encephalopathy, and what are the features against totally featuring as B12 deficiency. So, what is there in neurological findings in B12 deficiency? That another thing we can mention in the differentials. So, like Romberg sign and positive Babinski sign and some, and so many other findings are there. Posterior column is affected, proprioceptive is affected. So these things would improve our presentation. Okay. Otherwise, great presentation. Congratulations. Good.
Thank you, sir. Now I invite Dr. N.C. Prajapati, sir. Sir.
Thank you, sir.
Dr. N.C. Prajapati. Dr. Shamik, please call, sir. Meanwhile, Dr. Piali, madam, would you like to have your comments, please, ma'am?
Yes, definitely. Vedant, that was an excellent presentation. You've highlighted almost everything. But when you think of a psychological disorder, you need to rule out so many other things which are physically present. So I did not find a thyroid profile. I did not find anything else. Did you keep a DD in your mind? A medical
yes,
DD?
Yes,
what were
actually, thyroid profile was also done, ma'am, and it
you
came
didn't
normal.
show that.
There was
you didn't show that. And what else could have happened if you had a DD? Of course, brain tumors or traumatic brain injury, you must have ruled out through an MRI or a CT scan. Then
ADHD.
there could have been some ADHD, yes. And then sleep
ADHD,
disorders.
Sleep disorder.
Sleep disorders, yes. You should have considered hyperthyroidism because there were hyperactive times where the child was behaving a little hyperactive also. So ADHD, then Cushing, and then it could have presented, sometimes there is one disorder, if you have to keep it in mind, temporal lobe epilepsy presents like this.
Yes,
so you need to rule that out as well. Before dubbing them as a psychiatric disorder, a bipolar disorder. And what is the prognosis of this child you've been treating now? How long?
Ma'am, 5 months. Now this is the
5
month.
months. 5 months. What is the status of the child at the present moment?
Ma'am, last follow-up was done on 1st July. She's taking her medications. Academic performance has also increased. Which was
in one
initially.
month, 1 month, you could not have said academically declined. 4 weeks or 1 month is too short a time to make her academically declined, So she's picking up now. That's very good news.
Yes,
and how long will her therapy be?
Till ma'am, till 18 years of age. So, ma'am.
No, normally bipolar disorders therapy is lifelong.
Lifelong.
They may improve, but the moment they leave the medication, they will again go into either a maniac phase or a depressive phase. So that part you will have to assure the parents that the child will be all right, but you need to take regular medication. consult the psychiatrist as well. Thank you. That was a brilliant presentation.
Thank you, Piyali ma'am. Dr. Shabik, have NC Prajapati sir joined?
His phone is coming busy. He's lost connection.
Maybe that's the reason.
I'm leaving a message, ma'am.
Yeah, sure. Yeah, Dr. Manmik, would you like to have some comments?
Many more faculties have joined. We can have their views also. Dr. Gopika.
We will one by one we'll take it.
Ma'am,
Please give your comments.
Yeah, ma'am, we discussed when we listened in the rehearsal also. It is a very interesting case. Although clubbing everything together seems like we are fixing the things into one diagnosis. As Piali ma'am was telling that the academic decline will not come so sharply and cannot be, collaborated with the rest of the evidence. But maybe in bits and pieces, this is definitely a atypical case of a 12-year-old. Basically, it is a preteen, and at this age, romantic, fantasization or getting into a thoughtful thought of a relationship is definitely a totally a different game. Because for me, I've never seen such a young patient with psychosis because of the whole thing. So definitely a great thing. But I think we can take this case in bits and pieces, like two, three different things happening, and not maybe in rhythm or not in a flow.
Yeah. So regarding that preteen behavioral pattern, maybe Dr. Manmit, it is quite now becoming a little commoner.
Commoner, yeah.
Yes, and the internet exposure, I think they might be watching pornography, they might be watching a lot of romantic stuff. That is a kind of, and this child did not have a clear romantic relationship ideas, as Dr. Vedant pointed out. I think that kind of a vague ideas and vague romanticism, and of course, pornography exposure may be a cause of premature sexualization in this case. Yeah, so I would like to have more comments from the other faculties. Who else are there? Dr.
Maybe we can ask the mentors to first pitch in.
Yeah, we will definitely. But before that, as Dr. Manmeet pointed out, there are other faculties who have joined. If they have some comments, we will have one or two comments, and thereafter we will go to Dr. Shailaja.
Dr. Gopika, I could see.
Dr. Shamik, सबको म्यूट करें ना please.
वही कर दो.
Okay, so I think if there are no comments, I would like to have some comments from Dr. Shailaja Mane, madam. Dr. Shailaja, आप muted है. Shailaja ji, you muted. I think he has some issue with the Dr. Shamik.
I have joined from my mobile.
Okay.
Yeah, thank you. Yeah. Thank you
Yeah.
for the opportunity for the students, and congratulations, Dr. Sushma Ben and Shamik and Manmeet and entire team of AHA for this very important and much needed initiative. And it gives patient and builds the confidence also. This case was really very complicated, and it was teamwork along with pediatricians, adolescent health physicians, psychologists, and psychiatrists. Thankfully, we are having a couple of people who are having experience of managing teens and young adults also. So thank you once again. Thank you.
Yeah. Thank you. Dr. Sharda, आपको कुछ कहेंगे Dr. Sharda?
Yes, ma'am. This child was actually basically admitted in our unit. So she created a lot of havoc in the ward. She used to throw things, objects. She had a lot of anger outbursts. So she was a little difficult case to handle. And she used to beat her parents. She used to throw things here and there. So that is why a lot of multidisciplinary approach with the help of psychiatrists, psychologists, counselors was taken in this case now.
Very nice. Yeah, it was okay. Dr. Shraddha, that was an excellently managed case because you had a teamwork. Okay, so
Thank you, ma'am.
Dr. Vedant, surely it's an out of the box. I would like to say first thing first, the choice of case is really good. This is a kind of case which gives us a kind of goosebumps even at this age and at this stage of practice. Second thing is, of course, you have taken care of every aspect of history taking. You have taken, as you have taken mental status examination and the depth of the points which you tried to elicit. I think that was a history in depth, and that is really good. Another important thing is, of course, there are differentials, and I am really happy that you included vitamin B12 in the investigations, and the thyroid, of course, you had included, and those were really, I think, good. The point, one point I would like to say, the hallucination and disorientation, these are never the feature of ADHD. Never. So when there is a hallucination, auditory, visual, any sort of incoherent speech is not a feature of any other thing. A mild psychosis, it is only psychosis which has all these features. So your first diagnosis should be psychosis, that's fine. Of course, there are some factors which we have to keep in our mind, and definitely the first one is vitamin supplements, because both the vitamins, they may lead to aggravate the mood changes. They may not directly lead to psychosis as per se or such a severe symptoms, but surely they will aggravate the underlying thing if they are there. So that is one thing. Second thing, this child, because there are some kind of a premature sexualization, the features definitely are there in this child. We have to look after her sexuality part in a very, I would like to say, very closely observed manner. You have to have the counseling regarding the sexuality, regarding the normative development, and the features related to the cyber exposure, over internet usage, pornography, and all that. We have to go for in-depth history of all these things. This child definitely with such kind of a premature at 11, at the age of 11, if she has such a kind of strong sexual the ideas, and as you said, she was narrating it in an socially inappropriate manner. This is the child who we have to think about two things. One, we have to protect her from sexual abuse because she is the right candidate for sexual abuse. And the second, we have to think about
HPV vaccine.
Yes. So ये child जो है, apart from antipsychotic drugs, she requires a lot of social, medical, psychological, counseling support, all sort of things she requires a lot. And this is the case who has to be very regularly followed up, because such case, if it is a bipolar, surely, then such case, when they are in the hypomaniac or depressive state, they are the most dangerous people. This child can attempt suicide. She is the child who is rightly, as Dr. Shraddha was narrating, her definitely the maniac phase was very violent. Since such children can have exactly very, very low depressive phase. So in that case, we have to be extra vigilant. So these are all things probably parental guidance and other stuff does matter. An extraordinarily presented case and an excellent choice of the case. Thank you so much, the mentors, Dr. Shailaja, Dr. Shraddha, and the presenter, Dr. Vedas. So I think let us move on to the next one. Thank you so much.
Thank you.
Thank you, Vedant, and your entire team from the D.Y. Patil Medical College. Stimulating
Thank you,
discussion.
Sushma and entire team.
Thank you, sir.
So really stimulated quite a bit of discussion, constructive criticism, and I think so points for you to work upon. And of course, with every case, it will continue to be a learning experience, isn't it? Can I now call upon the next presenter, Dr. Chavi Singh, to upload her presentation and start sharing her screen?
Good evening, sir.
So Dr. Chavi Singh from the Government Medical College and Hospital of Chhatrapati Shambhaji Nagar is a junior resident, and she is here to enlighten us about the mysteries which the syndrome of PMOS always presents. Thank you, Dr. Chavi Singh.
Good evening, sir. Thank you, sir. Good evening, respected faculties, colleagues, seniors, and juniors. I'm Dr. Chavi Singh, junior resident working in Department of Pediatrics at GMC Chhatrapati Sambhajinagar. I would like to sincerely express my gratitude towards Indian Academy of Pediatrics and Adolescent Health Academy for giving me the opportunity to present my case. And I would also like to express my heartfelt thankful note for my mentor, Dr. Shilpa ma'am, for helping me for making this presentation over and over and doing corrections and helping me in the small roles. Special thank for our HOD ma'am. Then she is always guiding us and providing us whatever we need. And she is all enlightening us. So without further ado, I will start the presentation on PMOS, a mystery to be solved. A 14-year-old adolescent female girl, first by birth order, Hindu by religion, born out of non-consanguineous marriage, resident of Chhatrapati Sambhajinagar, brought by relatives with chief complaints of weight gain since 2 years, irregular menses since 2 years, and excessive hair growth since 2 years, informant being mother and herself. History of presenting illness. The girl was apparently asymptomatic 2 years back when her parents first noted a gradual increase in body weight. The weight gain has been progressive, predominantly involving the abdomen and trunk, with no history of sudden weight gain or edema. Around 2 years back, she developed menstrual irregularity. The patient also developed progressive coarse hair over the face and the body. As my patient had menstrual irregularities, I would like to focus on menstrual history first. The girl attained menarche at the age of 10 years. Initial menstrual pattern of the patient was regular, which was regular menstrual cycle for the first 2 years after menarche, which lasted for 4 to 5 days with cycle length of 30 to 35 days. Last menstrual period when child presented to us was 9th of June 2026. Previous to that, her cycle was 9th of April. Now child has irregular cycles with the duration of 4 to 5 days with cycle length of 45 to 60 days. Amount of blood loss was 3 to 4 pads per day with history of dysmenorrhea present, not requiring medications. There is no history of intermenstrual bleeding and no history of passage of clothes. Now for the negative history, I would like to rule out the important differentials. As the child didn't had rapid onset excessive weight gain, generalized body swelling, and facial puffiness, I would rule out the cause of endocrine or cause of obesity. The child didn't have polyuria, polydipsia, polyphasia, no history of cold intolerance, constipation, hoarseness of voice, dry skin, and easy fatiguability, suggestive of hypothyroidism, no history of easy bruising, recurrent fractures, proximal muscle weakness, and purple stria, suggestive of Cushing syndrome. No history of headache, visual disturbances, or galactorrhea, which was suggestive of pituitary lesion. There was no history of ovarian tumor, ovarian deepening of voice, rapidly progressive hair growth, or increased muscle mass. There was no history of passage of clothes, as I stated, which was suggestive of gynecological pathology. There was no history of snoring, witness apnea, choking episodes, and there was no history of chronic use of drugs. As I'm stating for the adolescent history, I have taken a HADS criteria. For the home part, the child will live with the parents and 2 siblings. The child feels safe and loved, and there is no recent changes in the his family. Education: the child studies in 10th standard, which is moderate and having moderate scholastic performance. There is no frequent school absence. Eating and emotions. Body image issues as the child presented to us were very major. The child also eats a lot of junk, concerned about weight and no intense cravings. And the child mostly stays home, no physical outdoor activity, only household chores. A child also had a good peer relationship with the other friends, uses phone for 2 to 3 hours per day. There was no drug intake. The child was sexually inactive, no intention of suicide, depression, or there was no risk-taking behavior. There were no frequent mood changes and no changes of self-harm. Past history, there was no history of hospitalization, chronic illness, surgical intervention. Personal history was within normal limits, as I've stated, and hence more of it. Immunization history, child was completely immunized till 10 years of age, as per the parents' history. Now coming for the dietary history, the child is a child consumes mixed diet, eats 3 major meals with frequent snacking 3 to 4 times per day, which majorly include junk food like chips or sweetened beverages. Uses phone for 2 hours per day as screen time. The child had protein deficit of 30 gram per day, and the total calories that were 1960 kilocal per day, and the total protein the patient consumed was 35 gram. Now looking for the pedigree chart for this patient, I have taken the red marked is the 14-year-old female which is suffering from the disease, and her paternal grandmother has a significant history of diabetes mellitus and hypertension since last 10 to 20 years. No history of PMS in any family member. For the socio-economic status, the child belonged to the lower middle socio-economic status as per the updated modified Kupus-Fami scale 2025. Anthropometry, weight of the child was 65 kg, height of the child was 155 centimeter, which lies between the 0 to -1 standard deviation. BMI of the child was 27, which was more than 97 centile. Waist to hip ratio, more importantly, which was 0.93, which was very significant, and waist circumference was 91 centimeter. As I have plotted for the WHO growth chart, the child lies above the 97 centile. And this is the IAP growth chart which I have plotted. The child's weight was above 97 centile, and the height lies between 0 to -1 standard deviation. Development history. Child has achieved all gross motor, fine motor, language, social milestone which were appropriate for age. Clinical summary. This is a 14-year-old adolescent girl first born to a non-consanguineous marriage who presented with progressive increasingly body weight for the past 2 years and irregular menstrual cycles and coarse body hairs for the past 2 years. She also developed progressive coarse hair over the face and body along with acne during the same period. There is no history suggestive of endocrine causes, chronic systemic illness, or developmental abnormalities. Her immunization and development history are appropriate for age. Going for the general physical examination, a child was examined in the sitting posture in adequate daylight with the proper informed consent from mother as well as the patient. Child is calm, conscious, and is well oriented to time and place and person. From head to toe examination, there was scars on parietal region. Face, the hirsutism, body hair, face hairs were present. She had acne, and acanthosis nigricans presented over the nape of neck. Stria over the abdomen were present. Breast examination, there was tenor staging 4, breast development, pubic hair, tenor staging 4, pubic hair stage development, and there were no pallor icterus, lymphadenopathy, clubbing, cyanosis, or edema. For the hirsutism in the woman, we use a modified Ferriman-Galvey score chart. The score 2, we use upper lip, chin, chest, upper back, upper abdomen, upper arms, forearms, thighs, and legs. The child had upper lip and chin hairs, as stated in the score 2. And in the chest, she had few terminal hairs. And for the upper back, upper abdomen, upper arms, forearms, thighs, she had the score of 2. And for the legs, she had 3, which was dense hair. The total score was 18, which was suggestive of moderate hirsutism. Now going for the modified tenor staging, the child had both for grade 4 tenor staging. For the SMR staging, it was B4, pubic hair 4, and SMR 4. For the vitals time, the rest of the vitals the child had within normal limit. Blood pressure was 126/82 mm of Hg, which was 90 to 95th centile, measured in the right upper arm in the sitting position using an appropriate size cuff. For the systemic examination, all systems were within normal limit: respiratory, CVS, CNS. Abdomen was full due to the central obesity. There was no organomegaly. Genitourinary, there was no signs of clitoromegaly. And breast examination, there was no signs of galactoria. I would suggest a few differential I would suggest few differential diagnoses for my case, which were PMOS, physiological pubertal anovulation, non-classical CAH, hypothyroidism, Cushing syndrome, and androgen secreting adrenal or ovarian tumor. For the ruling out my differential diagnosis, I will go for the investigations part. I did the hormonal investigation and the metabolic evaluation workup, which was thyroid function test and prolactin, which was within normal limit. Serum testosterone, DHEAS, and androstenedione were elevated. 17-OH progesterone, which was 2.76, which was normal. In metabolic evaluation, the child had HbA1c of 5.7%, which was suggestive of pre-diabetic range. Diagnosis summary: this is a 14-year-old adolescent girl, 4 years post-menarche, presenting with progressive weight gain, persistent menstrual irregularity, clinical hyperandrogenism in the form of moderate hirsutism, modified Ferriman-Galvez score of 18, and acne, along with central obesity and acanthosis nigricans suggestive of insulin resistance. Biochemical evaluation demonstrated elevated serum testosterone, DHEAS, and androstenedione, most probably a case of polyendocrine metabolic ovarian syndrome. Now, going for the management part, this patient would require a multidisciplinary approach. But for the first thing, the management of this patient can be divided into pharmacological, non-pharmacological. Dietary modification and lifestyle modification will be coming to the first thing. Weight loss more than 5%, dietary counseling, BP monitoring, as the child BP was more than 50 to 19 centile. Glycemic status monitoring, the patient had more than was in pre-diabetic range. Cognitive behavior assessment and the support. The patient had body image issues, and pharmacotherapy will come in the later stage if the patient won't recover, and the surgery would be the last resort. The cosmetic therapy for the hirsutism, like for the laser therapy, would be very helpful for the patient. Now, for the follow-up, as a PMOS patient is not like one thing, one sort of thing that she will come one day and she will be treated. She has to be followed every 1 month, 3 month, and 6 month, and every yearly protocols. Every time the patient would coming to the follow-up, we have to ask for the detailed menstrual history, how the old menstrual history we have to document, and what is the changing pattern of the menstrual history, and for the hyperandrogenic symptoms, whether they are improving or not, weight and lifestyle, and the medication. And every time we have to do a psychological assessment as well as the counseling. We have to go for the sleep assessment, physical examination, BMI and waist circumference. We have to document every time waist to hip ratio for the 1 month, 3 month protocol. We have to do for the lab follow-ups, which we can do for 6 months or 1 yearly. We have to assess for the treatment discourse and screening for long-term complications, and counseling and support at every visit. Now, going for the discussion part, as we are just engraved with the thing that PCOS, which is polycystic ovarian syndrome, has been converted to the PMOS, polyendocrine metabolic ovarian syndrome, as in 2026. The polycystic ovarian syndrome was engraved that every time if the PCOS comes, the child should have cystic appearance of ovary, and it is only just the gynecological cause. But the PMOS, as it changed, it has changed into 3 things. This is polyendocrine, metabolic, and ovarian thing. Polyendocrine, which is multiple interacting endocrine disturbances, which was going line from the brain to pituitary to adrenal, pancreas to the ovary. The hyperandrogenism, ovarian and adrenal androgens, neuroendocrine abnormalities, and insulin resistance, which is the first part which is affecting each and everything. For the metabolic part, the child has insulin resistant dysglycemia, which we have to go for lipid profile at every time. And the dyslipidemia can cause increased cardiovascular disease risk, hypertension, and obesity. These all symptoms. And last ovarian part, this is impaired follicular maturation and ovulatory dysfunction, ovarian elevated AMH, and may lead to infertility. The prefix they have kept for PCOS and to the PMOS, the poly maintains a degree of continuity with the familiar PCOS acronym while improving a scientific accuracy. Odds of composite cardiovascular MI and the stroke are significantly elevated as those with the PMS compared. And ovarian preferred over ovulatory. PCOS was ovulatory as it encompassed broader ovarian endocrine and paracrine function beyond the reproductive years. Now, the incidence, as I have taken the reference from international evidence-based guideline for the assessment and management of polyendocrine metabolic ovarian syndrome. PMS is in 1 in 8 approximately women, approximately 12.5% of our whole world is affected with PMS. It says that more than 170 million people are affected worldwide. It describes PMS as effective around 10% of reproductive age women worldwide. Notably, a significant proportion of affected women remain undiagnosed. Now, for going for the etiopathogenesis of PMO's part, the genetic predisposition and environment, both factors comes into the play and causes the insulin resistance. Hyperinsulinemia can cause into three things, which would lead to hepatic SHBG decreased production, can lead to polycystic ovaries, follicular arrest and anovulation, and ovarian androgen production, which would be leading for increased testosterone and androstenedione, which was leading for the hirsutism and acne part. Clinical features, there would be menstrual dysfunction, hyperandrogenism, reproductive, metabolic, psychological, and sleep and others. Now, going for the diagnosis of PMS, it varies between the adults and adolescents. In adolescents, only two features which we have to find for the diagnosis part: irregular menstrual cycles based on the number of years since menarche, and the clinical and biochemical hyperandrogen. I have mentioned based on the numbers of years since menarche because there is physiological till 1 year of menarche, the cycles are late, like 30 to 45 days. We can't label them as PMS. And then in adults, ovulatory dysfunction, hyperandrogenism, and ovarian criterion, which is polycystic ovarian morphology on ultrasound, or elevated AMH in adults. So now going for the diagnosis part on more details, ovulatory dysfunction, how we have to say for that the child is or the patient, the female is having ovulatory dysfunction. Oligoovulation or anovulation, which is oligomenorrhea, which is oligomenorrhea term has been obsolete, oligomenorrhea and then menorrhagia, cycle length which is less than 21 days or more than 35 days, which will both suggest that is the patient is having oligoovulation or anovulation, or the patient has less than 8 cycles per year. Hyperandrogenism symptoms like alopecia, acne, hirsutism, biochemical, increased total free testosterone or free androgen index. Or in PCOM or elevated AMH on ultrasound, if the patient has more than 20 follicles of 2 to 10 mm in any one ovary, or ovarian volume more than 10 ml per cube, or elevated AMH. Diagnosis of PCOS in adolescent require presence of the growth criterion 1 and 2, which are the ovulatory dysfunction and hyperandrogenism. Now, for the investigation part, we have to exclude the mimics, which is the hypothyroidism, as we have studied prolactin, and these we have to exclude adrenal tumors. Total and free testosterone with plus minus DHH will rule out the growth. We have to go for the PMS in like assess metabolic risk. We have to go for HbA1c, lipid profile, BP, and BMI. As we have done the AMH and pelvic ultrasound, which is not for the diagnosis in adolescent, but will rule if there is any complication helping in the child. Lifestyle management. The lifestyle management is the first forecast management for the PMS in a girl. 150 to 300 minutes per week exercise or 5 to 10% weight loss improves ovulation. As many studies have suggested, only 5 to 10% weight loss have helped in curing the whole disease part, and the patient doesn't require any medical or the pharmacological support. The psychological screening, sleep apnea screening, because we have to rule out whether the PCOS is happening, and the shared decision making we have to do. Now, for the management, we have discussed in the earlier slide also. I would like to say that the patient, as a PCOS or PMOS, the patient have sleep and stress issues. So we have to suggest the patient for adequate sleep, which is 7 to 9 hours per night, and effective stress management. Poor sleep and chronic stress can worsen insulin resistance and negatively impact weight, mood, and reproductive health. Regular sleep schedules, relaxation techniques, mindfulness, and physical activity can help improve metabolic and hormonal outcomes. For the counseling part, psychological counseling like managing anxiety, depression, and stress. Participation in PMS support groups provides emotional support, motivation, and improved treatment adherence. As we can talk, like the other girls also having PMS, so they can make a support group and they will help each other. Mindfulness, stress reduction techniques, and adequate sleep should be encouraged as a part of holistic care. How to talk to your patient, that is very important. What to say and what not to say when the child or when the patient comes to our clinic. Every time we see a PMS girl suffering or PMS patient, we are saying that the just you need to lose weight, you look so fat, why can't you control yourself, why are you eating all judge? And this is not just by their parents. We as doctors all sometimes do that non-intentionally. We just say that you must lose weight, stop overreacting, it's just PMOS. We have to start saying these things, which that I understand this the disease is difficult and I'm there to help you, which we have to be supportive and empathetic. We have to be start focusing on their health, not the weight. Encourage and empower the girls. Be realistic and positive. Let's set small and achievable goals like 5 to 10%. And there are many references which suggest that we can start from the calorie deficit diet for more protein rich diet. Respect her feelings and privacy. Do not ignore us or blindly ignore her emotions, and involve family positively. And one thing that like PMS patients are suffering is like they are suffering alone, which are making the disease prognosis difficult, which we have to keep smart goals, body image counseling, and we have to keep family also in the place, so that it's just not the 1% disease and she has to fight. Everyone has to help her. Now, going for the take home message, the future of women's health begins in adolescent. Every opportunity for prevention is an investment in generations to come. Lastly, thank you and regards. Thank you from the Department of Pediatrics, Government Medical College, Chhatrapati Sambhajinagar. Thank you, sir.
Thank you, Chavi, for a very, very insightful presentation. I would now invite the comments from Dr. Harmish Bhai, sir. Sir.
Ravi, a very good presentation. It looked like a guest lecture rather. You have mentioned all details and very good.
Thank you, sir. Thank you, sir. Means a lot.
You hardly left any scope for comments. But still, few things can be there.
Yes, sir.
In the title, we should write the details. Sometimes people like us may not be knowing what is PMOS.
Yes, sir.
Title में थोड़ा सा clear कर देना. I think that is one simple thing.
Yes, sir.
Secondly, during scoring of hair on the body, Perryman Galway scoring system,
Yes,
you
sir.
come to a conclusion of 18.
Yes, sir.
It would be better if we could have shown one slide on that. How do we score and in which parts of the body score is there?
Yes.
That will add on to some more beauty to your presentation.
Yes, sir.
So then in this patient, have you mentioned about the diet and physical activity as um, as part of treatment? In the end, you have very detailed, but in the management.
Yes, sir. I've mentioned about the lifestyle changes. For the dietary, there is dietary modification, weight loss more than 5%. Here, the physical status, as I mentioned, I will improve on it.
Yes, and इस patient का ultrasound किया था आपने?
Yes, sir. क्या investigation part we have mentioned. the USG was impression was suggestive of peripherally arranged follicles, which was suggestive of PMOS picture. But as the child was adolescent, and for adolescent, we don't go rely on just the USG picture, because there are maturing follicles which can also show the mimic of PMOS. So that's why there is I didn't highlight.
So this is one part of that.
Yes.
Another thing is in history taking, there is a history of lot of junks taken by the girl.
Yes, sir.
And nowadays, in this era, we have to give little more attention to the endocrine disruptors in the routine use. So,
Yes, sir.
are you aware? Means like uh, plastic use of plastic is there, plastic bottles and other containers.
Yes.
Then non-stick
Cookware.
and all that. And thirdly, especially in girls and ladies, the cosmetics,
Makeup.
fragrance, and those things. So all details, I think, maybe uh, um, important to give some more idea that what is the basic cause of the problem in this type of patient. So that is the thing. And nowadays, a lot of exposure, like some of the agriculture sort of things are also important if they have any garden or anything. So otherwise, excellent and congratulations.
Thank you so much, sir.
Thank you, sir. Dr. Prajapati, sir, has joined. Dr. Shami?
I'm not getting him, ma'am.
Not getting him? Madam? Piali, madam?
Yes. So,
Yeah, please.
excellent presentation, Shavi.
Thank you.
Covered extensively, absolutely. But now, one thing which I would suggest is that you should keep one slide which compares normal puberty versus PMOS.
Yes, sir.
Because then for everyone, it will be easier. Because see, irregular menstrual cycles are common during the first few years after menarche. That is normal. Okay.
Yes, ma'am.
Physiological acne, transient insulin resistance are common in puberty.
Yes, ma'am.
Mild hirsutism occurs. No?
Yes, ma'am.
It may be due to even for familial, or it may be familial or ethnic, whatever factors it could be there. So there is a challenge between normalcy and PMOS. So if you could just put that in, it would clear a lot of myths for a lot of people. Otherwise, excellent.
Thank you, ma'am.
Thank you, ma'am. Dr. Manmeet?
Yeah, ma'am. Again, we both the cases were really very good, and actually, that is the quality of case presentation is, I think, wonderful in both the presentations. And there's just an input that sir was talking about endocrine disruptors. I went across and I just had a article where Crocs, most of the people are now wearing Crocs, which are a very fashion fad with the youngsters. Although it was started as a beach wear, but now they are wearing it daily. And even it has been seen that Crocs also contain endocrine disruptors. And this is something that is in contact with them for a very long time, and especially when they are on beaches where there is sun, so that heat brings out all the endocrine disruptors. So it is a very important component of what type of lifestyle the patient is following, one thing. And secondly, you mentioned that the protein deficit is around 30 grams
30%.
for
30.
this. So that is a very important component, because we see that our youngsters are hardly taking protein, and if they are taking all types of synthetic proteins, which are again causing disruption in their neuroendocrine system. So wonderful case presentation, but definitely I think it was overwhelming to have all the information, from the, like, it was like reading through a chapter. Wonderfully done. Thank you.
Anyone else would like to have some comments? Chavi?
Dr. Renu is there, ma'am. Dr. Renu Boralkar had joined. And Dr. Manoj Rawal also I could see from this. Dr. Renu?
Dr. Renu, would you like to have some comments? Welcome, Dr. Renu.
No. Good evening, one and all. And it was a very excellent case presentation by both the presentees. And I congratulate AHA for excellent start of this series. Thank you.
Thank you, Renuji. Dr. Manoj, would you like to have some comments?
Dr.
Yeah,
Manoj
ma'am.
Rawat? Yeah.
Yeah. Thank you, ma'am. Actually, I joined late and I listened to Chavi's case, few last slides, and it was a very nice presentation. And I will be regular visitor now. Whenever there will be some these AHA presentation with it, I will be joining definitely in next
Most
few classes.
welcome.
Thank
Most
you.
We would
Thank you.
request you to motivate your students to present cases on this platform.
Sure, ma'am. Sure. I will definitely motivate them.
Yes, sure. So, Chavi, that was a good presentation, as I said, very in-depth and impactful as well. There are a few things. Would you like to label this child as PMOS? Label?
Ma'am, not currently, because labeling actually creates a stigma to the child, to the parents, and to the community. And this is a very adolescent child, matlab, like just 14-year-old. Labeling her just right now is as a PMS will be creating a havoc to her life. So I will be trying her to make her only understand her the lifestyle part, which she can focus on, which under the body image, as my patient had the significant body image issues. She presented to our Shilpa ma'am and to me with the scarf on her face in the hot summers, which is not very right because she was feeling very stressed about it. So adding a PMOS to her thing, which will be creating not, of course, I'm not labeling it, but I will make her understand the management part and the investigation we have already done with it.
What is the most important aspect of her life her parents and herself are bothered about? What do you think?
Ma'am, she herself is more bothered, but the parents as mother were the child didn't notice. She thought that it is a normal pubertal change, weight and everything. But the mother has noticed, like when she was compared to the other peers, that the child has more acne, more facial hairs. So that was a major concern of
What
the mother.
one point they are most bothered about is the fertility part. So we have to be extra cautious while counseling this child as well as the family members, because they are worried. Once you say it is PMOS, it is kind of the first thing is about the fertility, future fertility and marriage prospects. So this is one important thing we have to keep in our mind. Uh, do you think this is a simple PMOS, or would you like to have a PMOS with metabolic derangements or kind of a metabolic syndrome, syndromic features? Would you like to have it in this? Would you
Ma'am, I would
like to
comment,
call this case?
Thank you, ma'am. I would like to say this: the child is having PMS with an impending metabolic risk feature, because as the child had a HbA1c was lying in pre-diabetic range, we have to go for the OGTT, which is very standard and which is definitive for this patient. Secondly, we have to go for the secondly, the child BP was in hypertensive range, which was 90 to 95th centile. The child might be landing up to the metabolic diseases in future, which we have to counsel about them and have to start imposing about metabolic concern.
Why? Because you have not included the lipid profile over here. And the one important thing is in follow-up, you have to mention a very strict observation about the blood pressure. That's so very important in these cases. And even if this is not a PMOS or any other thing, blood pressure measurement in adolescent is a must. So this case particularly in follow-up, the follow-up with the metabolic parameters biochemically and the blood pressure, regular measurement of blood pressure, these are very important aspect of the management. Another important aspect is like, particularly in adolescent girls, you must have heard of the term PCOS clubs or PMOS if you modify the term, PCOS clubs or PMOS clubs. They are very, very well-functioning crew. And these children, because they are addressed alone, they feel a little bit, kind of anxious. There may be a lot of anxiety not only regarding the looks, but regarding the future and reproductive health, as I said.
So these children, when handled together in a group counseling, ah, the similar, the girls with the similar features, if they are grouped together, they are counseled in group, and when they get a chance to mingle with the people who are having the same problem, the same features and other stuff, they feel that they are not alone. Another important thing is they discuss amongst themselves very freely regarding their various concerns, which are sometimes not revealed to us as the doctors. And this way we can address their problems, we can give them a chance to, share their concerns and their worries. So I think this is one particular thing, because you belong to a medical college. I would suggest all the medical college authorities to have such PMOS clubs in their own hospital. And even the metabolic derangement, I would say metabolic syndrome is coming up like anything, the obesity aspect is coming up. So such clubs definitely help to share the, to have the adolescents share their common concerns, and group counseling is very, very effective in those cases. So that is one thing, and so that is it.
So, can I say something more, ma'am?
Hanji, sir, please.
You have very rightly mentioned, means this is part of the management. We have to be vigilant, and they may land in body image issues and low self-esteem, anxiety, and so many problems. So it's part of the management of these cases that we have rather anticipatory guidance and counseling about these issues, which may be just cropping up afterwards in these cases. Yeah.
Right. And the most important part, why do we not include the PCO morphology as a diagnostic, criteria in adolescent? There are three important reasons. One, the PCO morphology takes a very long time to develop. So if you take it as a diagnostic criteria, you may not catch them early. That is one thing. Second thing is the typically, as you very rightly pointed out, the multiple follicles, which are just the maturing follicles, they are very commonly found in the PCO morphology. You may not say exactly because the size is very small, but there are multiple follicles, which is a common finding in the adolescents, the pre-adolescents and adolescents. And the third very important thing is we do not recommend the vaginal sonography in girls, while in case of PCOS or PMOS, majority of the girls, not all, but majority of the girls are either obese or overweight, wherein the abdominal sonography is very, very difficult. So looking at all these factors actually, and the physiological aspect, it was not included by Endocrine Society. It is not included in the diagnostic criteria. So
Yes,
these
ma'am.
are some of the things. Purely. Thank you so much for an excellent presentation. And I would now like, the house is open for the comments. And I would like to have Dr. Shamik for his comments and the vote of thanks. Dr. Sawan, anyone who wants to comment?
Can I ask one question? Can I ask
Yeah,
one
please,
question, ma'am?
please, please. May I know your name,
Can you
please?
stop
I am
sharing
Dr.
your
Sabina
screen?
Vij.
Yes,
I'm from Delhi.
Yes, please, Dr.
I
Sabina.
have two questions. One thing is, how do you ask about the sexuality of a child of 14 years old, Dr. Chavi? How did you ask that she was sexually inactive or active? And the second thing is, when we advise lifestyle modification to an adolescent child, what would you advise in a local language? It's very easy to say weight कम करना है, diet कम करनी है, ये कम खाना है, वो कम खाना है. How would you advise in a local language, whichever language, for the lifestyle modification to an adolescent as in general?
Ma'am, firstly, thank you for the very relevant question. Secondly, as I asked to my patient, I asked whether she had any relation, either boyfriend, girlfriend, or someone she is interested in, whether she was in some kind of a romantic relationship, or I asked as the child was in 10th standard and the maturity, but I asked her directly whether she has and had any sexual relationship with any person. Now going for the second question, how can I ask a lifestyle modification for the in local language? Uh, so most of the time, my patient was consuming carbs, most of the carbs, as in sweets and sugars in her household, more of sweet and carbonated beverages. So I asked her start to reduce every day, try to reduce one chips packet a day. And second thing, for the diet, I didn't impose her the right diet. I just gave her the idea what can help her in the disease pattern. So I started having that if she is having a one thali, she has to include one bowl of a fiber, which has including all greens in it, like cucumber, carrot, or something which she likes. Second thing, she can have any green vegetables, which or the soya, as she was very interested in the protein source, which she never knew for the right protein source. I have asked her to include protein, paneer, tofu, or chicken, whatever she likes. For the protein fiber part, as you rightly said that we can't implement them what is the right diet. I just made her the thali thing which could be helpful. And at least for the physical activity, I last we met her 2 weeks back, and she was saying that she has 10th boards, and she doesn't have time even. So I asked that after having lunch she can go for 10 to 15 minutes of walk. As in PMS we have to go for 30 minutes of strenuous walking can only help also. And for the sleep we have to count, ask her try to not use phone 1 hour before the sleep, try to not have any carbonated beverage or tea or coffee, and try to have 6 to 8 hours of sleep. And for the stress management I ask her to have try to do pranayams or yoga. And then I guess that's what helped.
Yeah, so basically, Chavi, when we are addressing the metabolic syndrome, or when we are addressing the overweight child, the adolescent particularly, when we are having, so here one thing we have to keep in our mind, rather than repeating or instilling or what you can say is engraving in child minds that you are overweight, or we are actually focusing on weight. It is more important to focus on metabolism rather than the weight. Okay, because just focusing on weight, just talking about the weight, just talking about the weight management, a lot of exercise, a lot of stuff, rather than focusing on weight, let her understand the metabolism, the right type of a diet. Not only that, the right time for the consumption of diet is very important. And the thali concept, as you said, is absolutely in for the adolescent. We have to show them the thali concept only. So this is how we can say that, yeah, this is how you can modify your. And the life exercise. The life exercise are like climbing the stairs. These are a part of daily routine. Bicycling or walking to the school, or dancing, or any other activity with the child likes. So these are some of the things you can ask, explore, and tell them to do. That is very, very important, I think, and the child's compliance automatically improves. Rather than increasing the anxiety, because the anxiety in itself may aggravate the weight and stress eating. So that's a kind of very, very important thing. So anxious child may have a psychological eating. That again, a lot of craving and eating pattern, it gets disrupted. So this is what we have to keep in our mind while addressing the weight aspect.
Yes, ma'am.
Thank you so much for all the comments.
Thank you,
Dr. Shilpa, Dr. Shilpa would like to say something.
Thank you, ma'am. Thank you for the opportunity given. And I hope we were there to satisfy your this, because all the guidance you gave us, we tried to put it in the presentation.
That I
with
could
all the
see.
correction.
I
Yes,
could see.
yes.
Yeah.
Thank you so much
Thank
for
you.
the improvisations. We will take it ahead, for the next case. Our HOD ma'am, Dr. Prabha Khere ma'am.
Hello, Sushma madam, and I'm
Hello, Dr.
Hello.
Prabhaji. How are you?
Yes,
Very
I'm
happy to
fine.
see you, ma'am.
Yeah, surely. And I'm very happy to see
Oh, I'm really sorry for the other things, but all the best. And program was very good.
Thank you so much. Thank you.
Yes,
Stay connected
yes.
with us,
Thank,
ma'am.
Yes, there is a
thank you to all the
there is a call.
speakers.
She's in a meeting. Yeah.
Yeah. So I do not have any comments. I only have some appreciation to show on behalf of the Central AHA. So please allow me to share my screen. Right. So these shall be mailed to the individual participants. And this is our small token of appreciation. Can we have a round of applause for Dr. Chavi Singh for being a presenter?
Congratulations, Chavi. Keep
Thank
going.
you. Thank you,
so much,
Chavi.
ma'am.
Thank you.
so much, sir. Means
Can we also have a round of applause for Dr. Shilpa Pawar for
Thank
her
you. Thank you.
participation as the mentor? Thank you so much, ma'am, for having mentored.
Thank you,
Thank
sir.
you, Shilpaji, and
Yes,
congratulations.
thank you.
Can
Thank
we
you, ma'am.
have a round of applause also for Vedant for having tackled a very difficult case to the best of his ability?
Thank you.
Congratulations, Vedant. Keep going.
Thank
You have done a great job.
Thank you.
And a word of appreciation for his head of department, Dr. Shailaja Mane, as one of his mentors.
Shailaja
Thank
ji,
you.
we are so
Thank
proud
you.
of you and
all.
we are proud to have you with us.
And
Thank
of
you all.
course,
Thank you.
thank you
Thanks
to
for the
Dr. Shraddha
opportunity.
Salunke also for her
Yeah,
active
congratulations,
participation.
Shraddha ji. And I could appreciate your efforts to handle that case. Yeah, congratulations, the entire department of both the colleges. And we will be stay connected. And I look forward to having more and more connections and more involvement in the HA activities. We do look forward to having you all again and again. Thank you so much. Thank you.
Request to all the participants to please leave your email IDs on the group that we have created. So we will be sending these certificates to you on your mail. And before I end, can I request Dr. Samisha, who's along with us, for the final vote of thanks for this particular session?
Yeah, before Dr. Samir Bhai pitches in, I would like to show our heartfelt appreciation to the experts of today's BG Pulse program, Dr. Harmesh Mai sir. We are so very thankful to you, sir, for all the expert guidance and your support. I must say, you are always there with us, and we feel so proud of it. And our very own Dr. Piyali Bhattacharya ma'am, and we all have a lot of affectionate regards for you, and we have a lot of respect as well. Thank you so much for being with us, ma'am. Thank you so much.
Ma'am, Samir Bhai has had to
Sushma
leave.
madam.
Yes,
Yeah, Sushma madam, heartiest congratulations for this PG Pulse. Actually, and I want to say yes, that is the academics and really wonderful program you are doing. It is almost I was there initially, but now I handed over Shilpa because of other chores. But congratulations, hearty congratulations, and definitely
Thank you,
both
ma'am.
the PGs have done wonderful job.
Thank you, ma'am.
Including
Thank
their
you.
mentor. Yes.
Thank you, ma'am.
We'll see in conference again. Okay.
Yeah,
Thank you so much.
100%. Looking forward to having you all over in the national conference at Jaipur. Yeah, thank you so much.
Thank you.
And Manmeet ji, you are par excellent. Nothing to say more about it. And you always are there to help us. So a lot of appreciation for Dr. Manmeet Sodhi.
Thank you, ma'am. Thank you.
Yes, heartfelt appreciation.
And Dr. Samisha has had to leave for some other engagement. I'll request Dr. Arvind Sawant, one of our executive board members who's present here, to kindly propose the vote of thanks for today's session. Dr. Sawant, please. Dr. Arvind Sawant.
I think he has lost the connection or what. You can go ahead, Dr. Shamik ji.
I'll just check once more. He is there. But okay, nonetheless, thank you so very much to all our experts, to all our faculty, to all the attendees who have listened in for the last 90 minutes with rapt attention. Every such session, teaches us so much And as they say, that listening is probably one of the most active forms of learning. It's easy to be a critique while you are a listener, but then I will encourage a lot of the residents who have joined today. Please force your heads of department or your mentors to give you an opportunity to also be a presenter at this particular forum. We promise you we will not just recognize you here, but there are larger forums like Adolescent today, where good presentations will be published. And we also have the National Adolescent Conference, ADOLESCENT 2026 in Jaipur, where the 5 best presentations from the whole year shall get an opportunity to present at the national conference. So please encourage your mates to please join in, be presenters, and also make this program an even larger success. With those words, I once again thank everyone who's joined in today, and we promise to regroup again on the 3rd week of August with a fresh series of the PG Pearls program. Thank you so much.
Thank you. Thank you so much. Thank you and have a wonderful evening ahead. Thank you.
Thank you. Thank you all. Thank you, Sushma Pen, Shamik Bhai,
Thank you,
Manmeet.
Shailaja.
Thank you all.